Please be sure to like, share, and subscribe.
Because they're like, oh my gosh, there's going to be a mismatch. You know, what if you give mom low titer OPA's whole blood? And I'm like, you know what? Mom's alive.
We really need to start thinking about our paramedics, you know, and our EMS providers as pre-hospital clinicians.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
Well, it's an honor to be here today. We got a cool show.
Very cool.
We've had world record holders on the show. We've had some really interesting guests, but we haven't ever had 3 guests in one show. We've had 2, but 3 in one show, a bunch of wonderfully talented medical directors. Of course, if you're joining us, you've been here before with Matt. Why don't you tell us a little bit about yourself, Matt?
Oh, nothing to tell. Firefighter, paramedic, registered nurse here in the Dallas area.
Dr. Ball?
Yeah, ditch Dr. Ball. Yeah.
Okay. I'm Dr. Axene, medical director and ER physician. I've
Renaissance man.
3 friends with me here today.
Yeah.
Really, we got a great discussion on whole blood today, and we got really some unique perspectives. So, without further ado, I'm going to Dr. Bobko, Dr. Gamber, and Dr. Simmons. And we'll have each of you guys, if you could just introduce yourself briefly, and then we'll get right into it. Let's start, ladies first. Dr. Simmons, why don't you tell us a little bit about your history and your perspective on whole blood? A little bit about yourself.
Hi there. I'm Dr. Cynthia Simmons, and I'm the medical director for the Arlington EMS system, which includes Arlington Fire Department and American Medical Response as a transporting agency. I've held that role for almost 18 years and also practiced emergency medicine. Been in the ER for almost 30 years. Happy to be here.
Awesome. Thank you. And awesome. Glad you're here. Thank you for joining us. It's early. Not as early as for Dr. Bobko. Dr. Bobko, why don't you tell us about yourself?
There's the awkward silence between me and Mark. My name's Josh Bobko. I'm an ER doc and EMS physician out in a small place called Orange County, California, and we have earthquakes and avocados. But occasionally we do see some fire, and right now in Orange County we don't have blood, but it is rapidly sort of expanding through the state through different areas going to apply for local scope of optional practice, and we can talk about some of that process and some of the regulatory things that are affecting who's doing it, who's not doing it. So look forward to being part of that discussion.
Awesome.
Hey, Dr. Mark Gamber. I'm an emergency physician and the EMS medical director for Frisco Fire Department. And Frisco's had a blood program since December of 2019. We started as an exchange program with a local hospital that's a level 1 trauma center. And we started with component therapy, and then we evolved into carrying whole blood. So happy to discuss that program over the last 5 years.
Awesome. Thank you, guys. Great introductions. Now, in our last episode, we talked about hemorrhagic shock. We just filmed a lecture in San Diego. I was swimming with great white sharks, and we interviewed a gentleman who was on Good Morning America. He was bit by a shark, and really neat story.
Yeah.
Keen, who agreed to be on our show with us, and on the lecture. Sorry. Mm-hmm. And so we talked a lot about hemorrhagic shock, and we wanted to be able to bring in whole blood. And so that's the genesis of this podcast today that you're participating in. So we're grateful to have you here.
I think it's that, and too, that whole blood is starting to become more mainstream within EMS. For the long time, it's been mainly critical care, flight, medics, nurses that have been doing whole blood, and now it's like my department, like we talked about, we're starting a whole blood program within this year. And so, Dr. Gamber and other facilities out in, or departments out in California sound like they're doing that as well, and then Arlington. So this is kind of becoming more and more mainstream, and I know like anything, what firemen love, changing the way things are, right? So it's one of those new things that every firefighter is going to have, and why do we got to do this? But there's a lot of data that shows this is really good stuff that we're going to talk about, and it's very important that we know when to use this, how to use this, and why to use this.
Yeah, nobody would argue about a STEMI or an occlusive MI and how the time is heart, right? Kind of the adage, time is heart. And with stroke, time is brain. And with hemorrhage management, time is blood loss. You could bleed out very quickly. So getting blood as quickly as we can, that's really the whole pathophysiology of what's going on with this type of a patient. I was reading, not to get too far ahead of ourselves, but it was interesting to me to read that exsanguination is the number one killer of trauma patients, and half of them are in the pre-hospital environment. And then if you added on the medical indications for a transfusion in the field, that number doubles. So I mean, there's a huge patient population that would fall under this bucket of needing a transfusion in the field. Mark, we talked a little bit a couple days ago about some of the medical indications outside of trauma. And as you've been actually on the front lines delivering blood, what types of patients have you seen? Can you give us some specific examples, maybe a story of a save?
Yeah, I'd be happy to. We're about 50-50 split between trauma and medical. Recent medical cases would include a dialysis shunt bleed. If you've ever seen one of those take off, I mean, it goes quick. And so we had a dialysis shunt bleed and hemorrhagic shock that we transfused. Another recent case was a postpartum hemorrhage that was in hemorrhagic shock that we transfused. And then certainly GI bleeds are a pretty frequent medical cause. There's been kind of a proliferation of anticoagulants out there, and it doesn't take much for an upper GI bleed to take off and meet hemorrhagic shock criteria as well. So those are just a few examples.
Go ahead.
Oh, go ahead, Matt.
I was just going to say, like, we had kind of talked about the science behind hemorrhagic shock and blood administration in the field. I know, Dr. Gamber, you said you did I'm sure all of you have done plenty of research on what does the data show as far as administering whole blood pre-hospitally. What are the benefits? Like, again, most EMS providers are going to want to know the why. Why are we doing this? Is it really going to have an impact? Do we really have that many patients that this is going to affect? I know we've kind of touched on that, but what does the data tell us?
Well, I can tell you, there are multiple trials that have been done, and I know one of the big ones was the SWIFT trial, and then there was also another pre-hospital blood transfusion initiation coalition where they studied 1,500 patients, and there was a 2% increase in mortality with every minute of delay of transfusion of blood based on that study. So I know, and it also, and you guys correct me if I'm wrong, from a trauma perspective, it's really only penetrating trauma that showed the significant benefit.
Really?
Yeah, just the penetrating trauma. Blunt trauma, the evidence hasn't been there. And the pathophysiology of a blunt chest trauma as opposed to a stabbing. I know
It's
ED
interesting
thoracotomies.
that we used to teach this. Yeah. We used to teach the golden hour, the old legacy golden hour, and that mantra is really not holds true for hemorrhagic shock. And so utilizing blood in the field has really improved survivability. And there's multiple studies that have shown that.
Yep.
Yeah, and I think, Eric, to your point, you're probably referring to the refill trial, which is a UK center study where they were, it was about 80% blunt trauma, and it didn't show that there was any real survival benefit between standard care and transfusion. But I think before you kind of get into it, you kind of have to see how like these studies have evolved. So just quick going back to that, it was majority blunt and minority penetrating, but they also had some interesting time points where there was a bit of what we would call like remote medicine, where the on scene, like getting to the location was up to 30 minutes in some cases, and then they were on scene for an average of 20 something minutes. So you're already at 50 minutes before you're getting blood plus transport. So I think what Dr. Simmons was alluding to was that as shock progresses, you start in running into organ failure pretty quickly, and then you get into a point of irreversible shock where you essentially can't turn the process off. And so with some of these studies, it's really important to see, how it's being implemented and when it's being implemented, because that drives the results. And I think, to kind of go back to what I was saying originally, is, this all came out of the military, right? We've had the global war on terror for 25 years. And fortunately, those lessons that we've learned from the blood of our colleagues and our veteran friends have kind of driven this research. But there is a little bit of a difference, because some of the early studies from Dr. Stacy Shackelford and John Holcomb, they were looking at some explosive type injuries as well, in addition to gunshots or blunt trauma. And so that's like a completely, when you start including amputations, it's a little different than what we see in traditional EMS. Doesn't mean it's invalid. It just is a little different. And so then it started evolving into some of the civilian trials, like the Pamper, which was the air medical trial. And then that one was given plasma. And then you had the combat trial. And then that one was looking at, after trauma, and they kind of disagreed. They were about, I don't know, Mark shaking his head, maybe 2018, 19, maybe when you were starting your process, and you kind of, the initial impulse was good, and then the studies would disagree, and then that's evolved, and now you're starting to get really pretty good data coming out of like New Orleans and Houston, and in the last year, even 2024,
yep,
that has really kind of changed the tone of transfusion pre-hospital, because I just don't think we didn't know what we didn't know, and the studies were evolving, and now we're at a point where people are actually doing it, and you can look at your own system and your own processes and come up with data that's usable. So just wanted to throw that in there, because I think there has been an evolution in these studies as it's become more broad spread. Sorry to talk too much.
No, that was really keen. I wonder, have you come across like a minimum size department or demographic where the whole blood programs, based on the data, actually have the benefit? A tiny little department wouldn't have the benefit necessarily. I think there's probably a certain size and maybe more of the urban.
Yeah, I think it's like you were saying, when your department, there might be one patient a year.
Right.
Is that worth the hassle of implementing a whole blood program for one patient a year? That sounds terrible to say, but at the end of the day, that's reality. I know in my department, we looked at it, and last year they kind of looked at the numbers, and I think we were looking at roughly 40 to 50 patients probably, and that was just roughly looking at the indications would have received. So that's a pretty significant number.
How about you, Mark? How many do you have per year?
Some of those smaller departments are rural, and those are the patients that are most likely to benefit from blood because they have longer transport times. So if they can get a hospital that would support their program and the finances that would support the program, those are the patients with extended transport times that could absolutely benefit from it. And that's been proven, actually. I believe the PROMIT trial has proven it both in penetrating and blunt trauma.
Mark, how many patients do you have a year with your blood program at Frisco? What's the data there?
A little over one a month is the average for the last 5 years. So, 5 years, 60 months, about 75 transfusions. So that's a city of 250,000. It's a community that doesn't have a lot of penetrating trauma. We're going to be, it's going to be more blunt than penetrating, and it's going to be, obviously, there's medical. That's about 50% of the cases. And just to kind of, be balanced, I think it's appropriate to have is the juice worth the squeeze, because there's an upfront cost, there's a lot of training. So you got to look, to Dr. Simmons' point, geographically where you're at. I also serve as Plano Fire's EMS medical director. There are about 300,000 people. And Plano has looked at this very deeply too and chosen to hold off from carrying blood, whereas Frisco has moved forward. And when you look at the two cities, Plano has a level 1 and a level 2 trauma center within the city that have whole blood in the ER. And this is, whether it's component therapy or you're doing whole blood, there's just a lot of logistics that we'll talk through on this podcast about that. But there's just not a scenario in which, like in Plano, I have 13 fire stations. We can't put that at 13 fire stations. This is a living tissue donation that we just don't have enough of. So most cities put it on like 1 or 2 vehicles. And, the question in Plano for all of us was, can we get the blood to the scene before we can get the patient to the hospital? And in our equation, when we ran the maps and the transport times and things, we felt like the majority of the time, we're going to get to the patient to the hospital faster than we can get blood to the scene due to the short transport times, level 1 and 2 trauma centers. Frisco is a little more distant from those. We don't have a level 1 or a level 2 within the city. And so when we, when we looked at that, we had a lot of construction, we had a lot of significant injuries, but we didn't have a level 1 or a level 2 close by. Transport time was going to be 20 plus minutes. It's not rural, but it's not, urban and right on top of a trauma center. It made more sense to do that. And so we initially started out with blood on one asset, a squad program that could self-dispatch anywhere in the city. We evolved, and over the last 2 years, we actually have blood on a bat chief vehicle, 1 on each side of the city. So we kind of split it east and west. And, we can get into it now or later, but I think there's an important conversation around not just sort of external advertising and talking about a blood program, but there needs to be constant internal advertising to all your medics to talk about that first arriving engine. When you're looking at your call notes, what are you looking for to get the bat chief on the way also with the blood? Because the dispatchers can't always pick that off. It's got to be an internal sales job amongst all your firefighters to go, okay, it's GI bleed, I need to get the bat chief there with blood, or if you have a squad program, I need to get the squad there with blood. And then the folks who carry it, they've got to be actively listening too.
That's a good point.
Yep.
Dr. Bobko or Dr. Simmons?
I was just gonna jump in there. I think what makes blood a little bit different in EMS versus some of the other things that we do, like for example, sepsis, trying to get people to recognize sepsis, looking at, we're driven by quality indicators and how are we doing on these things. But at the ground level operationally, my firefighter medics don't necessarily see that the helping recognize sepsis earlier in the hospital process is, they don't see the end reward of that, other than at the end of the month we say, hey, good job, our number is this or that, and that's pleasant. But I think blood is a different thing where, when we were asking about, is the juice worth the squeeze? Well, it is to somebody, right? And when you've been on that case and you don't have any other option, and then somebody is gray and dying, and then they're better, that does have a significant impact. And I think that's maybe why it's resonated a bit with, fire EMS people, because so many times they're put in that situation where they can't control a lot of things. There's a lot of things working against them, and this is kind of something that gives them a solution that's achievable, attainable. And I think that may be why it's kind of resonating.
Yeah.
One question I have for you guys as medical directors, that I know a lot of medics, because I wasn't introduced to whole blood or even component therapy until nursing school and then critical care school. So for the average run-of-the-mill EMS paramedic, for the average fire department paramedic, explain to us the benefit. When I went to paramedic school 20 years ago, it was, you got trauma, it was 2 large bore IVs and pour the fluid to them, right? Obviously, we've learned that's a terrible idea now in trauma. Why is whole blood, explain to the average paramedic why whole blood is better than just volume with fluids?
Well, fewest amount of words, I would say give them what they lost.
Exactly. Yeah, we've talked about that in our hemorrhage
Exactly right.
lecture.
Yeah, it's not hard. It's not rocket science. It's just you're losing blood. You need blood. That's exactly what you need. You don't need a lot of crystalloid. You don't need a lot of saline or lactated ringers. You need blood. That's what you're losing, and that's what you need. And the idea is 1-to-1. A lot of studies out there have shown 1-to-1 is what really improves survivability. And I will play off of what Dr. Bobko and Dr. Gamber said earlier, in that bringing it home, we unfortunately in Arlington had a firefighter that was shot in the chest. And having lived through that experience, we did not have blood. We're still in the process of getting a blood program, but if we had that, to use it to treat one of our own would have been prudent and wise. And so I think to bring it home, even to take care of our own people, is just something that we need to do. And blood is there. Blood can save lives.
Dr. Simmons, I think your point is well taken. It is just as important for patient care as it is for protecting our own. And it's our firefighters, it's our police officers, it's our tactical teams. You in Arlington have these incredibly high profile events, and, we have to think about how we take care of our first responders when those things come up. And Matt, to your point, I think about things very simply, and I just think about the Kool-Aid is on the concrete, right? So we're spilling Kool-Aid, and, earlier, Dr. Axene, you talked about stroke and heart attack. That's ischemia of the heart, ischemia of the brain. Trauma is full body ischemia. And so with fluids, we just diluted the Kool-Aid. Your oxygen carrying capacity is spilling all over the concrete. And with just fluids, you've just diluted the Kool-Aid and the oxygen carrying capacity, and your whole body's ischemic. So we need to replace that oxygen carrying capacity. Otherwise, people die, their whole body's ischemic, they go into multi-organ failure from hemorrhagic shock. And so we're just bringing the medicine to the people by carrying blood. It's just, as long as you can get through the logistics, it's not that big a deal.
Dr. Simmons, Dr. Bobko, have either of you looked into the number of people you would have, hypothetically, if you had a blood program?
We haven't done a full review of all of our charts, but we certainly have anecdotal reports, and we probably have 2 or 3 a month that we think we could have given blood to, potentially. So, but certainly I think 2 or 3 a month is what we're looking at.
Yeah, I'll tell you, over the last 3 years, we're looking at about 275 people. Wow. I put some of that information into, did some statistical stuff to try to create a map, and so I know what cities that we would probably start in as well. And so, but I think maybe that's the next segment of the conversation is, then why doesn't everybody have it, right? Because there are some things, and we're talking about protecting our own. I use that example all the time with airway, right? Like, we shouldn't be sticking eye gels in firefighters ever. So the same goes to blood, and I think what you look at where those two connect is, again, I think it was out of New Orleans, the Tulane study actually showed decreased intubations. Because one of the highest risks for trauma is obviously peri-intubation and perioperative arrest, because we haven't properly resuscitated. So they were actually looking at the number of cases that had to be intubated, that were, traumas that were, had whatever their ISS score was. And I think it was, the number intubated was about 10%. If you got blood, it was about 10% of the cases that did not get blood that got blood, meaning I think it was about 12% for people that were normal resuscitation, about 1% for the people that got blood. And that's a really big deal going into an OR. And you find out that, you're not even having to intubate these people, and their hemodynamics just improve. You kind of turn off that cascade. And I think that's something else that is probably going to start coming out in the literature as well.
Well, that's huge in healthcare. I know from a healthcare perspective, we can minimize complications. We decrease healthcare costs tremendously.
Sure.
I mean, in an unrelated but very related topic, I mean, you can, by preventing an OR stay or by preventing even a genetic disease that you could have screened for, the screening cost saves the healthcare system a ton of money. So even though these blood programs might be expensive, but by getting patients blood early, you've prevented the intubation, you've prevented the need for the ICU potentially, you've prevented the need for the OR. I mean, there's a lot of very powerful things, Dr. Bobko, you've brought up that add a lot of value. In the healthcare world, we call those soft savings. They're not direct savings, but they're soft savings. And by seeing the benefit of it from a healthcare perspective, you can save a tremendous amount of utilization of a higher level of care, which is in our healthcare system, we need more thoughts like that. We have a very expensive healthcare system. And I think the pre-hospital use of blood, I think we've established that. The science behind it.
Yeah, the evidence is there. The
evidence is there.
That backs it up. Yeah, it's exciting for me as a EMS guy from the fire department, right? That gets all kinds of slack from the fire gods. That there's something I can actually do now for my trauma patients. Where in the past, you go on these major accidents and maybe it's a prolonged extrication time, and I'm sitting there itching like, my patient's dying right in front of me and there's nothing I can do for them. Like giving them fluids isn't going to help. I can intubate them like you talked about. They need blood. They need a trauma surgeon, and there's nothing I can do for them here on the street. And it's extremely frustrating from a guy that, like I said, is EMS minded, that this is something that's relatively simple in concept to do. Obviously, the implementation sounds like it's a little bit more complicated, but it 100% saves lives out in the public. And I think, any EMS agency needs to look at the benefits of doing this. I know, Dr. Simmons, you talked about rural departments. I know like funding is a big problem with a lot of smaller rural, even volunteer departments. And the benefit there is that they can call for, flight. Typically if they have a big trauma out in the county and they have an hour ground transport time, they're calling for a helicopter anyway. And those helicopters are bringing them blood. Typically, I used to volunteer in a small department, and that's where we would even fly a lot of patients from McKinney. Now we don't, because we've advanced our skill level. And I think we looked at doing a whole blood program about 6-7 years ago in McKinney. And from my perspective, I wasn't a fan of it because I knew where we were at from a provider education and ability level, and we were not doing the basic things at that time correctly, and there wasn't enough there just wasn't enough people. I knew that people weren't going to do it. Even if we had the ability to do it and we trained them to do it, the majority of the department was not going to do it. Now,
Dr. Gamber said the internal advertising.
Exactly. Yes. Guys, you can have all that, they talk about a dose of diesel. Well, a dose of diesel doesn't, again, like in a prolonged extrication, you don't have that option, and the blood is the option there. So you have to have buy-in from the folks that are going to be doing this for sure.
Well, that's the perfect time. Go ahead.
Yeah, this takes coordination, it takes communication, it takes internal buy-in, it takes protocols, it takes coordination with the hospitals, it takes logistics and equipment, refrigerators and temperature sticks and other things like that. It takes money, it takes coordination and communication with the hospital who's supplying the blood, returning the blood before it expires. So to your point, there's a lot of preparatory work, I think, that has to go into a program. We've been working on our program for over a year, and we're still not in service yet. Right now, we're working through legal issues. So there's a lot of different things, and Mark can probably, Dr. Gamber can probably speak to that since he's been through those logistics. But it's taken us a year, and we're almost at the end phase, but it takes some work.
Yeah. Let's take a quick break before we get into that, and we'll come back and talk about the next two parts of that, which is implementing the program and then the indications for the patient.
Yep, and then pitfalls and challenges.
Yep. Let's take a quick break.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
We're back.
Already? I didn't see the countdown. Man, I'm glad you're here. Well, we had a great first segment. We're going to hit up part two here. Great discussion on some of the science and the evidence, and some of it pun intended, bled into this, but I think the indications and the challenges and pitfalls will be an interesting conversation with Dr. Gamber, Dr. Bobko, and Dr. Simmons. So indications for it, identifying the right patient.
Yeah.
When we did our hemorrhage lecture recently, we were trying to educate our students on the importance of early identification. Early identification, and in this case, I think identifying the patient that really would have the benefit of a field transfusion. And we want to be a good steward with the blood that we have. Certainly, if we're just throwing it around willy-nilly, that's not going to be a good thing. But as far as indications go, we talked a little bit about penetrating trauma versus blunt trauma. I know, we don't need to talk about the specifics necessarily, but in identifying a patient in hemorrhagic shock, there's a lot of education that has to happen to be able to identify that patient profile. Dr. Gamber and we talked a little bit about this a few days ago, just looking at the profile of a patient's vital signs. I mean, we don't want to treat numbers and just start throwing blood out there. It's more to it. There's a clinical context. Mark, what are your indications? Can you just run through, just at a high level, your protocols and what you use?
I'll cover some of the indications, and it's a lot about context too, right? So you gotta, because some of it's based on vital signs, and if a teenager wrecks their parent's car, they're going to be tachycardic and tachypnic. And they might trigger some of these things, but they're not bleeding, and they're up walking around, so you can't just be algorithmic and go, they were in a wreck and they're tachycardic. So you really, the top of the protocol reads, in the setting of hemorrhagic shock with suspected need for mass transfusion due to marked internal or external blood loss. Like, I need you to commit to you really think they're bleeding, not just that they're having an anxiety attack causing abnormal vitals. So once you're committed to thinking, man, I think there's a big time internal or external bleeding, then the indications for us are, anybody with a systolic of 70 or less is automatically a candidate. Anybody with a shock index that's over 1, so ours is going to be like a heart rate greater than or over 100 with a systolic blood pressure at 100 or less. That's another indication. This is where we started this early, but we chase end-tidal CO2 as an indicator, and we think it's been pretty accurate. So big shout out, first of all, as Dr. Bobko mentioned, to the military, and then this went into San Antonio as a big military area and a very early adopter. So I consider CJ Winkler and Dave Miramontes, and then some of the military trauma surgeons down there as kind of the forerunners into translating this into the civilian theater. And so I just begged, borrowed, and stealed from those guys. And CJ and I talked a lot about using end-tidal CO2 as an indication. So 5-6 years ago, we started saying, look, if your end-tidal CO2 is 25 or less, in the setting of what you think is hemorrhage, then we're going to say yes to transfusion. We find over the last 5 years for us that's been very accurate, and I think CJ would say the same thing. And then any witness cardiac arrest less than 5 minutes prior to arrival in the setting of trauma. Or GI bleed, we'll use as an indication as well. And I used to have some specifics around this, but I've learned to just trust the firefighter spidey sense. So basically mechanism based. If you think you have significant penetrating trauma, now if a kid in school stabbed another one in the foot with a pencil, that is penetrating trauma, but that is probably not something that's going to cause hemorrhagic shock. But anything that looks significant to you. So I didn't, because I've seen people, bleed out from an arm or a leg GSW. So looks significant, penetrating trauma, that's an indication for us to transfuse, irregardless of vitals. Because Wayne Gretzky said, skate to where the puck's going to be. Sometimes we get there so fast, they haven't knocked their vital signs to a point it would indicate it. But if you see a bunch of holes in somebody, you know where they're going. Go ahead and transfuse them.
Two questions. It sounds, the criteria that you talked about, it sounds identical to the sepsis criteria, except without a presumed source of infection, you have a presumed that your patient is bleeding. Everything else sounds the same.
Yeah,
Is that
that's great. It's different forms of shock, right? You've got septic shock, your body's falling apart. You got hemorrhagic shock, your body's falling apart.
Do your guys automatically transfuse blood in a traumatic arrest, or only because hemorrhage is the #1 cause of death and trauma, as we know? Do they automatically do it?
If we can get it there, we do, if we can get it there.
Okay. Just curious how that worked.
You mentioned identifying hemorrhagic shock, and I wish I could only have so many studies up here with me, but there was a study done on folks, guessing how much blood was lost, and we're really bad at it. We're really bad at it. Was it 100 cc's of blood, or was it 2 liters of blood? There's a wide range of guesses. Mm-hmm. So I like what you said, that spidey sense, Dr. Gamber, and trusting our paramedics, which I think has a lot to do with training, which we'll get to with challenges. But I think as far as indications go, identifying that patient population is key. Any other thoughts, Dr. Bobko, Dr. Simmons?
If I may, I just wanted to, I think that trust is a really big deal. And I don't know, Dr. Simmons, your experience. But one of the issues that I definitely have noticed, at least in our local area, is I think there's a little bit of a hospital-based misunderstanding of pre-hospital transfusion. And in fact, I've had conversations with some of our trauma docs in not necessarily the university setting, but some of the community trauma centers that perceive some, because there is a scarcity for resources, they perceive some competition with EMS for blood, right? And the argument kind of goes, if there's only so much blood, first off, the argument may be, I can't even get whole blood in my trauma bay. That's number one. And then within the systems, you'll have a hospital that has whole blood and another hospital that has just blood components. The second is, if I can't even get whole blood in my trauma bay, then why should it be on the ambulances? Wouldn't it be better at the trauma center? Since I'm a trauma surgeon, we have all the bells and whistles. But I think there's sort of a fundamental misunderstanding from a hospital-based perspective of what we are trying to do. I'm sure, as my colleagues will attest, and yourself as well, we just want to find the people that need the blood and then give them the blood as soon as possible. Like I don't really care who's got it or how it happens. I just want them. I want us to get really good at identifying it, and I think that's where, sort of the like the Minutes Matter trial kind of starts to show, where for your odds ratio for mortality goes up 11% per minute. We need to start looking at can we really do what we say we can do? Because sometimes, when you get to the hospital, things don't always just happen instantaneously. There's always got to be, there's a dispatch, and then there's a call, and there's a dispatch, and then there's on scene, and then there's treatment, and there's transport. Then you get to the ER, and then there's another assessment, and then there's got to be an order, and then it's got to come up. Somebody's got to run to grab it from the blood bank and then bring it up, and then by the time it's in somebody's arm, it's, again, I think it was the Minutes Matter showed that it's like 26 minutes, right? Yeah. So we just have to do better, but we have to bridge that, or we got to crest that trust mountain of, we're going to do this as a system, and we're going to trust our people to do it sooner rather than later.
I'm glad you brought up trust. That's huge. And we can't be in all these places. Our hands are working through the hands of our medics, and that's enormous.
That's a perfect thing for the providers to know, the paramedics out there. So I teach outside, and one of the departments that I taught at recently went to sequence intubation, or basically brought on paralytics, right? And it was a new thing for that fire department. And a lot of the questions I got when teaching the medics was, well, why do we need to do this? They're going to do it at the ER. And that was, Dr. Bobko, the same thing that you just said was what I told them was, they would say, well, our transport times are only 5 minutes. Okay, but you're on scene. You're not immediately going to load your patient and leave the minute you get on scene. You're going to be on scene for a few minutes. Then you have a 5-minute drive. Then once you get to the hospital, there's a delay before the doctor comes in or whoever comes in. So you're looking at 15 to 20 minutes of that patient is hypoxic. And as we all know in trauma, that's a really bad thing, or in anything, that's a really bad thing. So we can do that in the field and, help those patients. It's the same thing here. If we can give blood in the field, we're dramatically increasing our patients' chance of survival. And so, like you said, it doesn't really matter who gives it. If we don't get the patient to the trauma surgeon at the hospital, he's alive. He's got nothing to work with. But
No, that's good. So we have the indications here, and I think you've kind of brought up a challenge. This is developing that trust with our whole healthcare community. Yeah. This isn't a one person job. I mean, this requires a group of people. It's like a link. We're just a link in this chain. Dr. Simmons, you talked a little bit about some of the legal challenges. I guess we could jump into that now. Some of the challenges of this. What legal challenges are you having, and what can you share with us?
Well, so again, I think it's we have a combined entity where I'm at, where we have a private vendor that's doing transporting and a fire-based first responder organization. And so for us, it's a matter of coordinating and communicating with those two entities along with multiple receiving facilities, all from different hospital systems. So we have 2 level 2s and 1 level 3 trauma center, really 2 level 3 trauma centers that are in close proximity of our transporting radius. And so communicating and coordinating, and like was mentioned previously, I think some of the biggest pushback that we've actually had was initially from the blood bank and them not wanting to give up their precious resource to the EMS systems. And so we've had some sit-down communication and meetings with the blood banks. We had to prove and sort of show our temperature regulation. So we've done several months of freezer temperature regulation monitoring to show that we have responsibility and communication and have training to be able to return the blood before it's expired. And so all of the logistics of the program, to be able to work with our colleagues and with the attorneys from each of those respective agencies. So it's involved a lot of coordination and communication at many different levels. But there's an absolute benefit in it, an absolute life-saving potential. It's just a matter that the logistics and the meetings have to occur, whether it's from blood bank or hospitals or different agencies, EMS agencies, and the attorneys for all of them.
Now, we here in Texas, we're in a more of a progressive environment. Dr. Bobko, you and I talked yesterday a little bit about some of your challenges with the way that your medical direction. I think you have a county medical director who functions under the state medical director. Is that kind of how it works? Is that right, Dr.
Yeah,
Bobko?
So again, trust me, the last thing Texans want to hear about is California. I respect that tremendously, so I won't bore everyone. But yeah, basically California cedes the authority to what are called local EMS authorities throughout the state, and then those local EMS authorities kind of set the tone. There are things that are agreed upon at the state with sort of common scope of practice, this kind of thing. Medicines, but you can apply for local optional scope of practice, and those have to go through the state process with the okay of the local EMS authority. So again, I'm totally the wrong person to have. You should probably have Steve Patterson on here from Corona Fire, who has the first running blood program in the state. I know Ventura, Los Angeles, city and county, Sacramento, and I know Riverside, San Bernardino. Everyone has gone through that process, so they're in varying stages of implementation. But Steve in Corona's number one, so I got to give him his props. I think former Loma Linda colleague of yours.
Oh, I didn't realize that. What's his name again?
Steve Patterson.
Steve Patterson. Very cool. Was he an attending out there? Oh, okay.
Yeah. So he's been attending. I think he works a lot out at Riverside.
Okay.
But I know he's the medical director for San Bernardino Sheriff's Air Rescue as well. And just an all around great guy. Like if you need anything in California, he probably knows how it works.
Ah, very cool. Well, those are interesting challenges in California. And, actually, from my perspective, this is one of the coolest things of this collaboration right now is to hear Dr. Simmons and Dr. Gamber and I communicate with you and Dr. Bobko in California, and to see how some of the struggles are the same, but they're different. We have more in common than we have different. I know Texas is a whole lot different than California. We kind of joke around about that, but it is
Austin.
Really cool. Say it again?
Austin,
Except for
just
Austin.
like California.
Keep it weird, right?
Something like that.
That's right. So,
but
no,
I think to the point, and then I'll end the California part of this. At least for us, the way that it has to work, we don't have sort of the delegated authority. So for us, depending on your local authority, you may be able to do some of these local applications or trial studies, or you may not, and that's kind of how it works. And if you are in a place where that it is a little bit more progressive, then generally that kind of filters through the system. And then in other places, we've talked about some of the rural. I know Dr. Simmons was talking about some of the rural areas and not having money. I'm in Orange County. We have all the resources in the world, and we have long transport times for people that like to live in the canyons or down by the beach. But the system has to be willing to make this change, and sometimes it takes quite a bit of pushing, because everybody likes to stay in their little comfort bubble, and that's really, I think, getting these messages out and talking about the new studies and the places that are doing blood, like Dr. Gamber, like creating their own research that other agencies can pull from. It's going to be super important for some of the people that are on the sideline waiting to see what happens. There's everybody's always waiting for the mythical study that says, here's exactly how we should do it and why.
Yeah. Well, Mark, you're working right now with the whole blood program. Now, we could talk about a ton of different challenges and pitfalls. You've experienced a lot of them. And Dr. Bobko and Dr. Simmons are experiencing them currently. But as you move through and have been in a program now since 2019, maybe you could talk a little bit to some of the challenges and pitfalls you've experienced, whether it's storage, transportation, blood handling, supply chain issues, training, all that. Maybe just tell us a little bit about your experience.
I think the first thing was sourcing. So we were inspired by a case. We had a really interesting field amputation case. The guy was in hemorrhagic shock, and air ambulance brought blood to the scene. And we were inspired by that and thought, maybe we could do that too. In San Antonio, the regional blood bank is really good about working directly with EMS, but that's probably not true in most of the United States. There's not necessarily a mechanism to give back. One of the primary tenets of our program is we don't want to waste the precious resource that's given to us. So how do you do that? Because the expense is something. I'm going to ballpark it at about $500 for a unit or so.
That's what I got.
So that's potentially a cost. And so we needed somebody that was willing to give us blood and take it back if we didn't use it, because we knew we weren't going to be an incredibly high utilizer. We knew we would use it sometimes. Local blood banks in Dallas-Fort Worth weren't ready for that yet. So we went to a hospital, and I would say you probably want to go to a place that's a level 1 trauma center, because they use a large volume of blood. When we started in 2019, that was mostly component therapy, packed red cells and platelets. And you think about all the surgeries that go on at level 1 trauma centers, much less all of the anemic patients, like cancer patients, that get transfused, and they're using 100 plus units a week easily. So if we weren't using the asset, we could bring it back and it would get put in the pool and used immediately, and there's no wastage. And as long as there's no wastage, there's no charge then to the fire department, which makes it a budget neutral program for our taxpayers, other than some of the upfront costs. So that's how we got started. We developed a contract with a level 1 trauma center that was kind enough to sit down And like Dr. Simmons mentioned, they wanted to look at our processes, which is totally appropriate, because if we're bringing the asset back to them, they need to know it's safe to put into their patients and that we've been a good steward with that. So that's where there's roughly a $10,000 upfront expense when you're looking at getting temperature monitoring systems. You're looking at getting, fancier coolers. We even went to the point of getting one of those Hemler blood fridges, just like, the blood banks have, at our main fire station. So, just ballpark, think about $10,000 for upfront cost to get this going. And then you got to think about blood warmers too. And do you just put that on the one resource, the unit that's got, in our case, the bat chief vehicles? We actually, after a while, put the blood warmers on all of our first line apparatus because we wanted the patient with a line-in blood warmer primed and ready to go, so that as our bat chief showed up, everything was ready to go to just hang the blood, because we were trying to reduce the time to get blood in humans. We can't get blood on every asset, but on every apparatus, but we can get a blood warmer on every apparatus. So we've evolved to that over the last couple of years. So we circulate blood back through the hospital about every 10 days to 2 weeks, and so there's a lot of people, power that goes with that. Our shout out to Jack Sides, our EMS captain. He's been doing this for 5 years, and he runs a lap to the hospital roughly every 10 days to 2 weeks to drop off blood before it expires, so it can be used in the surgical pool and to pick up a fresher batch for our patients. And he's got a tight relationship with the folks in the blood bank. We keep logs, so we show them that we're being good. And here's the great news: 5 years, no wasted blood.
That's good.
If we use it, then we pay for it. But if we don't use it, it's an even trade for the new stuff. Now, going to whole blood has been something of the last couple of years, and you have to have a place that has whole blood, right? So your average community hospital is not going to have whole blood. They don't really have mass transfusion protocols at non-trauma centers or level 4 or level 3 trauma centers typically. It's typically going to be a level 1 or 2. And in order for them to have an exchange plan with whole blood, they have to use a lot of whole blood, because they can't give it out if they don't use enough themselves. So the hospital that we had the exchange program with, that's a level 1 trauma center, they kind of had to hit a critical mass of whole blood usage, probably about a unit a day, in order for us to be able to borrow some, put it on the field, and then bring it back if we don't use it, and they would still use it in time not to waste it. And that's the critical mass we've hit the last couple of years. We're now exchanging whole blood. Now, every once in a while they get short, so our protocol allows for either one. Whether we've got whole blood or component therapy, our protocol covers either one. So if we've got whole blood, we use that first. If we've got component therapy, we give them a unit of plasma, and then we give them a unit of PRBCs. If we've got 2 lines, we'll give both at the same time. If we got 1 line, we'll do the plasma first and then the PRBCs. Just talk about internal and external advertising real quick. There's a fun conversation around how you educate yourself as an EMS medical director, EMS officer, and then how you lead everybody else through that education process.
Right.
It starts with just doing military history. It's totally fascinating to look at World War II, the Vietnam War, the Korean War, and see what we did as we've evolved. And then you get into the operational. You got to get out the blood warmers. You got to get out everything and play with it as an entire department. This is not just a couple people. This is a program where your guy on the engine in the periphery of the city has to know the indications for the protocol and has to know how to get the line and get everything working. But just as important is talking to your local hospitals, because they got to understand what you're thinking about doing. And the trauma centers are going to be hip to the whole thing because they've already been doing it. But, what about a postpartum hemorrhage? What about a dialysis bleed? They don't necessarily need to go to a trauma center. And so now you're talking about taking somebody getting whole blood to a community hospital, and that blows some of their minds, right? And I mean, I'll give you a great example of it. We took a patient who was significant postpartum hemorrhage, hemorrhagic shock. We started transfusing her. We arrived to a local non-trauma center, and the doc said, "I don't know why you're giving her blood," and threw it in the trash can. Oh. And she continued into hemorrhagic shock, and the doc had to then order multiple units of blood for her. Oh, no. And she ended up a few days in the ICU. She had a good outcome, or I wouldn't be bringing it up right now, but it's sort of an education point that you really have to go on the talk track at all your hospitals. And you know who gets really wound up about this is the pathologists of all people. Because they're like, oh my gosh, there's going to be a mismatch. You know, what if you give mom low titer OPA's whole blood? And I'm like, you know what? Mom's alive.
Yep.
Mom is alive, so baby's alive. So we'll worry about the next pregnancy now that she's
Marcus,
alive.
just on that note, it's an interesting dilemma because, you know, that's the thing that they are most concerned about in the world. And you're kind of telling them, you know, yeah, we have bigger problems.
Rocks their world.
So that must have been a fun conversation.
They're like, but you're not checking, and you're not. I'm like, they're gonna die. You know, let's get them alive to the hospital because all these indications we just went over, they're indications for dying rapidly.
Do you have a study to show that?
That's what's happening.
And so, sorry, a lot of that is that's just sort of the anecdotes of life, like you're saying. Some of the research is catching up to what we're doing, but it takes people like us just leading on it.
Yeah, there's just a recent study that just came out that shows that with low titer whole blood, that the risk of allotransfusion with a pregnant mom was at max 7%, and much less than that in most cases. And so, again, yes, for a mother that's hemorrhaging, it can be life-saving, absolutely life-saving.
Yeah. In fact, I know there was a
ahead.
military study that I had read, and I'll have to find it. I'll send it to you, Eric, so you can add it. But I think their incidence in the military was less than 1%. So, I mean, these are very large, much larger numbers than any one trauma system or any one EMS system.
It reminds me of a time I was. Go ahead.
And one of the things we did too was offer to have blood drives with our pathology and blood bank, and that was received very well, especially if we offered to have like our recruit classes, our fire recruit and police recruit classes. A lot of young, healthy people donate a lot of blood, and they absolutely loved that idea. So it's a negotiating tool.
That's all. It reminds me of a time I was talking to a nephrologist, and he was so concerned that I was going to cause kidney failure in this patient who was dying. And listen, if this patient survives to the ICU on dialysis, that's a miracle. We're given the contrast. No, this is a good place for us. I think we'll just get ready for a summary here. I wanted to give each of you a time just to say something, final words. Dr. Simmons, any final words here before we finish up?
We've been teaching March algorithm, and we've been teaching, which is different than we originally taught, and we've been teaching golden hour, but I think we've come to a place now where the science shows that we can do more than just stop external hemorrhage, but we can actually treat and replace hemorrhage and prevent severe hemorrhagic shock from causing lethal complications. And it doesn't take a lot of blood loss. It takes about 40%, 30 to 40%, and somebody's in severe shock, and that's not a lot. And so we can really treat through the use of whole blood cells and whole blood, the complications associated with that. So I think there's a lot of logistics that have to go into any program, and kudos to the organizations and medical directors and departments that have gone through this. We're in the process of that currently, and have gained and earned a healthy respect for the logistics that are required. But I think that at the end of the day, we're here to provide the best patient care that we can for ourselves, for our providers, for our tactical officers, and for our citizens. And so I think that whole blood is one way that we can do that.
Dr. Bobko?
Sure. I'm following on Dr. Gamber, Dr. Simmons' coattails, all of the people that are kind of making this happen. I think what I would issue maybe a challenge to anybody that's listening or watching, that I think the trust component is a really big part of EMS, and I think that there is this. Some places have an overriding sort of dogma of considering our pre-hospital men and women as technicians. And I think and as a result, when you limit the amount of tools somebody has, when you kind of put them in that box, then the amount of output and the amount of sort of thought that goes in, you're limiting as well. And I think we really need to start thinking about our paramedics, and our EMS providers as pre-hospital clinicians. They're going to recognize the same criteria that I'm going to recognize. And so we have to put a little bit of faith in them to make that decision for the benefit of the patient, and then give them the tools to do something about it. But it's very hard for hospital-based and office-based system administrators to do that without having those relationships with the men and women that are doing the job that we're asking them to do. So I really would ask that for my colleagues that are listening, and for the chiefs that maybe are listening and you're thinking about doing it for your medics, our medics see more trauma and more codes than pretty much anybody in the world. So to think that they're just technicians, I think, is dramatically underselling the capability that is out there, and we need to put some trust into that capability.
Wow, well said. That's awesome. Couldn't agree more. Dr. Gamber?
Yeah, this is one of those mid-career shifts when some of us between residency, me included, we were still back in the days of let's give a lot of fluids and maybe we'll get around to giving a little bit of blood, and we were diluting the Kool-Aid. And as we learned and changed our practices and evolved as a trauma center, we moved to different ratios of component therapy and eventually to whole blood. And it's incumbent on EMS medical directors like us and EMS chiefs to take the medicine that's in the hospital and immediately ask ourselves, how can we push that outside? And to Dr. Bobko's point, we have incredibly skilled clinicians that can deliver this stuff. I think the medicine is now irrefutable, that whether you've got access to component therapy or even better whole blood, get what you can and figure out how to get it in your system if it makes sense for you and you can afford the time and the training to do it. I think the juice is absolutely worth the squeeze to do it. And the other thing I'll just say is, from a morale perspective, this is a really cool thing. Our job is to practice great medicine as EMS medical directors, and also to serve as motivators and educators about how cool what we do is every day. And when we got together as a fire department and said, we're going to do this, and we got into the committees of going, where are we going to put the blood warmers, and where are we going to carry the blood, and how quickly are we going to cycle it through? It was a ton of fun, and it was just a team-building experience. And I find that the medics I work with in Frisco are that much more fired up about being medics because we have this program. I think it's very empowering, and when you do things like this, you're saying, I trust you, you're doing some awesome stuff. And it's not just showmanship. Like, the medicine is great, the medicine is sound, but it's very much a morale-building program, too.
Totally agree. It's exciting. Dr. Ball,
Yeah.
you have any thoughts?
Not even close. Yeah, just off the heels of what they said, that to the firefighter EMS, private EMS providers, I find it very exciting that we're able to do this. We've talked about this a lot, and I preach this a lot, and I get a lot of kickback for this, but for 20 years, I've been a firefighter. I have never once pulled somebody out of a building and saved their life by pulling them out of a fire. And not only have I not done that, it's only happened maybe once or twice in my department in 20 years. That is kind of what people think saving lives is when you join the fire department, and that's not reality. If you're in Houston or New York or a big city, it happens obviously more often. But for most of us, most of the firefighters in the country, that is not what you're going to be saving lives doing. That's just not the reality. And this is something we train extensively. We go out to the training field and we drill on all these different techniques to save somebody out of a building, which I'm not negating that. It's super important. And a lot of times it's a firefighter that goes down and we need to get out our own. It's extremely important. that same level of importance needs to be placed on EMS and programs like whole blood programs. Because like Dr. Simmons said, whether it's a police officer or a firefighter that has, an injury or an incident on duty that we need to respond to, a tactical medic, a car wreck, whatever the case may be, we have to be just as prepared for a critically ill medical patient as we do a fire victim. We have to do that. And so as I would speak to the paramedics out there, that we have that responsibility, that if whatever your protocols are, if you're implementing a whole blood program or RSI or whatever the skill is, you need to be proficient at that skill. You need to know the indications. You need to know when and how to give this life-saving therapy to your patients. Like I said, I find it's super exciting to me. It is the future of mainstream EMS. I think it's coming more and more, and so we need to be prepared for it.
You guys haven't left anything for me to say. I agree with all of y'all. But I will say this, though, is that more and more people are starting to recognize the importance of what we do in the pre-hospital environment to the whole healthcare system, the whole continuum of care for our patients. It used to be, and Mark and I, Dr. Gamber and I've talked about this multiple times, is that it's been a long time coming now for people to recognize the healthcare journey doesn't start at the ambulance bay doors. Yeah. It starts in the pre-hospital environment with dispatch and bystander CPR and all this. And I think what's exciting for me, to Dr. Gamber's point, is that what we do is so exciting. And I don't think a lot of our colleagues really appreciate how much of an impact we can have on the whole healthcare system. That, to me, is super exciting. And I think what kind of surprised me today was how excited I got to even talk about how much trust is involved here. And I'm glad Dr. Bobko brought that up, because I think that trust, that relationship that we have between the healthcare system, the hospital, and the pre-hospital environment, the link between the two is us, guys. I mean, our medical directors are linking the two environments together. And that makes me very, very excited. So I've enjoyed our podcast today. I think you guys have been amazing. Thank you for your time and sacrificing your morning to join us on this podcast. This has been amazing. Thank you so much.
Yeah.
We like to end our podcast.
Yeah. We'll see you guys on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.